Hello, everybody, and thank you very much for joining us. I have another session today. We're basically trying to rebroadcast some of the highlights of the sessions that had been done, and one really nice one is Peter Prater talking about inverted papilloma. I personally have learned a lot of useful information during the session, and I wanted to share it with you again this afternoon. For the next 2 or 3 days, we will have 2 live sessions and 1 recorded session. They're all very, very interesting. I'm hoping to see you then. Here's the session on the inverted papilloma by Peter Prater, who is the chair of otolaryngology at Rush Presbyterian in Chicago. Please go. Thank you.
Yeah. Great. Well, thank you, Professor Tarabici. It's a pleasure to be with you and everybody else around the Middle East and the world this morning. We're in an incredibly unprecedented time, and I hope that everybody who's on the call is safe and healthy, and so are your loved ones. You know, I've been to many parts of the world and met people and shared meals and talks and knowledge. And it's an interesting time that we're now doing this virtually, but I hope that our paths will cross again in person in the future. So my talk today will be on diagnosis and endoscopic management of inverted papilloma. It's a disease that I've managed certainly for 18 years. I've written a lot about it. I've given a course at our American Academy of Otolaryngology meeting for about 15 years. So I've obviously followed the literature very closely as well. So I'll share with you some of my experience in managing more basic and advanced cases over the years and bring everybody up to date on the knowledge. These are the objectives. We're going to go through the histopathology, a little bit of time on the pathogenesis. We'll talk about the role of endoscopy and imaging. We'll talk about surgical strategy for removal of specific subsites. We'll look at maxillary, ethmoid, frontal, and sphenoid separately, and then we'll appraise the outcomes as they're available to us in the literature. So just very briefly on the history of inverted papilloma. Initial description almost simultaneously in the UK by Ward in '84 and Billroth in '85. And Ringertz described in 1938 the entity as we've come to know it and recognize it as inverted papilloma. Himes was a pathologist at the Armed Force Institute of Pathology in the United States, and he has really been credited for giving us the current kind of classification scheme of sinonasal papilloma into its subvariants of inverted, fungiform or exophytic, and cylindrical, and also called oncocytic cell subtypes. So this is the most common benign primary nasal tumor. The Danes keep an amazing registry, and when you look at their data, the incidence of sinonasal papilloma is roughly 1 in 100,000. So not an incredibly common entity, but something that most of you have encountered, I'm sure, many a times. And as you know, there are the 3 distinct varieties: inverted, which is clinically the most relevant, exophytic, and then the oncocytic variant, which is a slightly less common. Let's look at these 3 briefly from a histologic standpoint. When you look at exophytic, typically this arises in the nasal vestibule. As you see here, this one is on the left side, arising on the nasal septum. When you look at this histologically, you see this exophytic growth pattern of the stratified squamous epithelium. And then this connective tissue core, and then has a very high association with human papillomavirus. Now, contrast that to inverted papilloma, where you don't see an exophytic, but instead an endophytic growth pattern, where you can see here, this is actually growing into the underlying connective tissue course. It is also a stratified squamous epithelium. You can sometimes see respiratory or transitional epithelium, which can actually throw off the pathologist. And then typically you see minimal mitoses or atypia, just showing you a very classic example of an inverted papilloma, and I'll show you many of those endoscopic images throughout the talk. The third common variant is the oncocytic variant. It's also been called the columnar cell papilloma. And you'll see this papillary mucosa that you see here. When you look at this endoscopically, this looks no different. This was a recurrent maxillary oncocytic papilloma that you see here. Typically, they arise from the middle meatal structures. They can be associated with malignancy. So really, from a biological behavior standpoint, they don't behave any differently than inverted papilloma. So I really don't make much of a distinction in how I manage one or the other. You still have to remove these completely down to negative margins. You still have to counsel patients that there could be underlying malignancy. It's just that they look slightly different on histopathology. Now, what's interesting is over my 18-year career, what I can tell you is I see more and more columnar or oncocytic papillomas now. I don't know why that is, but I wonder if their pathologists are getting better or are able to better differentiate the oncocytic variant from inverted variant. When we look at risk factors, there are no defined risk factors for why inverted papilloma develops. There's been a couple of interesting studies from the Far East that have looked at this issue. A study by Sham out of Hong Kong that's looked at a variety of different occupational and industrial exposures. And they did note that outdoor occupation or working in industry was statistically associated with prevalence of inverted papilloma. A study out of South Korea looked at smoking as a potential risk factor for malignant transformation in sinonasal papilloma. They looked at 162 cases, and 10% of those had squamous cell carcinoma arising in IP, and what they found was the risk of malignant transformation was almost 12-fold higher than the non-smokers. So when I see patients, if they are smokers, I will usually counsel them that there is some data to suggest that smokers may have a higher risk of this, and therefore stopping smoking would be in their best interest. There's been an incredible body of literature that's looked at the role of HPV in the possible potential pathogenesis of sinonasal papillomas. And if all of you were to look at that literature, you'll find there's a remarkable amount of variability in the prevalence of HPV, with some studies showing a very high prevalence and other showing a very low prevalence. So it really depends on detection methods, who's done the study, what part of the world the study might have been done. But this is a nice pooled study that looks at 76 papers of almost 2,000 cases of sinonasal papilloma, and you can see almost 39% had HPV positivity. Exophytic is most commonly associated with HPV prevalence. You can see almost 2/3 of the cases. Inverted, a little more than 1/3, and oncocytic, only about 1/5 of the cases. So you can look for HPV, just please note that you won't always find it. Now, how is it that HPV could possibly cause this? Now, we don't fully understand, but it's certainly possible that HPV leads to the synthesis of this E6 viral oncoprotein, and that may lead to degradation of the wild type or normal P53, which you know is a tumor suppressor gene. And if you were to have an imbalance and therefore an increase in the mutant P53, that could potentially promote tumor formation through loss of growth suppression. Now, there's an interesting study that I'm showing you here, published many years ago by Katori from Japan, where they looked at kind of a spectrum of inverted papilloma with dysplasia, even carcinoma, and then looking at p53 staining intensity. And you can see in controls, that is no presence of tumor, there is no p53. Exophytic, not much. Inverted papilloma with slight dysplasia or even moderate, not much. But as you work along this spectrum and you get into cases of severe dysplasia or carcinoma, you are more likely to see p53 positivity. And certainly, frankly, invasive squamous cell carcinoma, you see much higher prevalence of p53 positivity. Now, it's possible that there's kind of this hit and run hypothesis. In other words, you have HPV, it may be present at some point in time, it causes the formation of this E6 viral oncoprotein, and then perhaps the body clears the HPV, and if that's the case, it kind of sets off the cascade and then results in tumor formation. Now, I would say this is not fact, this is hypothesis, and I've had many discussions with colleagues all across the world, and so this is one possible mechanism, but the reality is we don't fully understand. The other very interesting hypothesis that was posited almost 2 decades ago by Don Lanza was this concept of inflammation, which may be a potential promoter for tumor formation, or certainly the inflammatory milieu may provide the nidus for tumor formation. They did a very interesting study looking at actually contralateral side to see if there was inflammation present from the side of the tumor. And you'll see these are 2 of my patients, and you see this inflammatory change that's present on the normal side. And we've looked at this many years ago when I was a young faculty at the Cleveland Clinic, where we looked at histopathology of IP versus exophytic and columnar cell subtypes, which showed a statistically significant increase in all of this inflammatory cells in the tumor tissue. When you look at the clinical characteristics, and I will refer you to this very large study that looks at almost 1,000 patients out of South Korea, a pooled national experience, and you'll see that the mean age is in the mid-50s. Most commonly, patients are in their 50s to 70s, and with a male to female ratio of 3:1. And certainly in the data in the US shows that there is a higher incidence in whites. When we look at the site of origin, inverted papilloma can really arise anywhere. It is true that it's most commonly along the medial wall of the maxillary sinus or the anterior ethmoid region, so kind of the osteomeatal complex, if you will, but you can find it anywhere within the maxillary sinus wall. Posterior ethmoid, certainly we're going to go through some cases of frontal and sphenoid disease, and it can arise on the septum as well. In fact, I've seen cases with mixed presence of exophytic and inverted papilloma arising on the septum. So it has no geographic boundaries. It can really arise anywhere. And here you see some classic endoscopic examples. You can see this warty appearance of this tumor here that I am starting to resect in this patient with a very large left ethmoid inverted papilloma. I'll show you more in this video, but this does not have the typical appearance of polyps. It is much more friable. It is much more bulky, angry and red appearing, although sometimes it can have more of this bland appearance. Now, the other diagnostic complexity that you should all be aware of and is the fact that they can arise in the setting of polyps. And this can certainly add to the diagnostic dilemma. Here you see a patient where this may look more like polyps on the lower aspect, but this certainly has a papillomatous appearance to it, and this certainly looks more like polyps. So they can arise in this inflammatory tissue, and certainly for anybody with unilateral disease, there really has to be a very high index of suspicion in these cases. When we look at the radiographic assessment, certainly when we look at CT, this is about as classic of a CT that I can share with you on inverted papilloma. Here you see this very large expansile, kind of this homogeneous mass, which is expanding the middle meatus here. Certainly cases that can be more extensive, they can cause bony remodeling, hyperostosis, or even bone erosion. You see the sphenoid IP. You see some contrast within the carotids. You can see significant loss of bone there. And really the key thing to look for is the area of focal hyperostosis. And that's really been shown to be predictive of the site of origin in almost 90% of cases. This is a case that was sent to me many years ago. This is a case that was partially resected and it's recurred. And you can see this area of focal hyperostosis along the inferomedial orbit, and that's almost always going to be the site of origin of the tumor. This one is slightly higher up along the lamina, just above the nasolacrimal duct here in the frontal recess, and that was indeed the point of origin as well. And this study, published a little more than a decade ago, looked at a variety of these radiographic signs to see what was the positive predictive value when you see a variety of these things. And I've shown you most of these, but you can really see here the presence of focal hyperostosis or a bony strut had the highest positive predicted value of being able to predict the site of origin of the tumor. Interestingly, just diffuse sclerosis or erosion or other things simply do not have that level of positive predictive value. Here's some more examples. A patient with a left maxillary IP, and you can see this very large area of bony growth here. Again, classic focal hyperostosis. You can almost be certain that is going to be the point of origin of that tumor. Right ethmoid IP, multiple previous surgeries. You see this area of focal hyperostosis here along the orbit. You can actually see this little vessel arising from the orbit, and you can see it's embedded right within that area of bone. And again, you would want to be very careful of that when you are addressing that area of attachment. Now, one thing that I've learned humbly over the years is, yes, the tumor's likely going to be attached there, and it's going to be attached there, but it does not preclude it from attaching from other areas. So just because you see an area of focal hyperostosis doesn't mean that it can attach to other areas. And I have seen that selectively in some cases where not only does the tumor attach to the area of focal hyperostosis, in fact, it can attach diffusely in many different areas. So just because you found one area, please continue to look to make sure there are no other areas. MRI can be helpful in these cases. And as you see here, in a case like this, again, previous surgical manipulation, ethmoid cavities opacified, maxillaries opacified, T2 weighted images can be very helpful in a case like this, because what you see here is on T2, maxillary is just all inflammatory post-obstructive secretions, while the tumor is actually within the ethmoid cavity. Certainly for assessment of the dural and orbital interfaces, I think it can be very helpful. And certainly you can look for this kind of columnar type pattern. This was reported by Maraldi out of Italy. And this has it can be a very reliable indicator for IP. And what you see here is this. This tumor tends to involute on itself. So these areas of bright signal are actually mucus that's embedded between the areas of tumor. And so you almost get these columns of tumor interspersed with mucus. And that, again, has a positive predictive value, almost 96%, according to this study out of Italy. Certainly on a case like this, I think MRI is critical. This is a patient that I inherited now almost 15 years ago. You can see the date there, 2004 on the scan. This patient had had 40 surgeries for inverted papilloma. And he presents really with essentially no nasal structures. The entire posterior ethmoid cavity is opacified by this soft tissue mass. And you can see some subtle erosion along the ethmoid roof. And in somebody who's had 40 surgeries, they absolutely need an MRI. And you can see here, this tumor actually went transcranial here, and you can see this knuckle of tumor going into the anterior cranial fossa. You don't want that surprise at the time of surgery. Here is a very large sphenoid, long neglected sphenoid inverted papilloma. And in a case like this, erosion over both the optic nerves, to understand what are these contents within the sphenoids, I think an MRI is again crucial. There's been a few staging systems that have been proposed, and I'll show you what we've done in this paper that I cite here. Steve Kennedy was one of our residents back when I was at the Cleveland Clinic, and we looked at these and we classified these tumors as stage A, B, and C. And this actually has some positive predictive value when you look at tumor location. So I'll come back to this and show you how we found this to be helpful in categorizing and almost simplifying the Krauss system, which is perhaps used most widely. I think this is also an excellent system. My only thing here would be that malignancy should be excluded from benign IP. I've seen patients die from IP with squamous cell carcinoma, so I don't think we should mix malignancy with a benign disease. As we start to transition to surgical management, one of the things that I want to really emphasize is that pre-op medical management in these cases is absolutely critical. There is a huge inflammatory component with these tumors, and giving them some antibiotics and pre-op steroids about a week before the surgery can really reduce the inflammatory component, can reduce blood loss, give you better visualization, and actually tissue that is somewhat questionable, where it may be inflamed mucosa and you may not know intraoperatively if it is tumor, is it inflammatory tissue, it can actually help normalize some of those tissues. I've had patients sent to me who have massive, a splaying of the nasal dorsum or nasal vestibule because the tumor is so large and it's just completely displacing their nasal structures. And I've given them a week of steroids and they'll come back and their nose will normalize, at least the external appearance, within a week. So there can be a huge inflammatory component, so it's important to do that. Now, a case obviously for aggressive surgical resection is critical. I don't think I should have to convince anybody on this Zoom call about that. However, I would emphasize 3 key points that you should document in the patient chart. I'm going to be seeing a patient later today. I have 2 cases of inverted papilloma that I have to do this month. What I will emphasize and document are the fact that they can be locally aggressive, so surgery is critical, and not to delay the procedure, especially when we're in the middle of a pandemic. Propensity for recurrence if you do an incomplete or subtotal resection, and the risk of underlying malignant transformation or presence in about 10% of the cases. It's critical that you discuss these 3 key facts of the biologic behavior of this tumor with every patient that you operate on. And certainly in a country like US, where the courts are the way they are, this is something that I would want documented in every single patient's chart ahead of time. Now, the role of endoscopy has certainly evolved. When I did my training in the late 90s, there were still cases that were done with open approaches, lateral rhinotomy, but majority of these can now, I think, be tackled in a very facile way using endoscopy. It really gives you affords you the ability of a single modality approach from pre-op to surgical resection to post-op surveillance. This is a recurrent sphenoid inverted papilloma pedicled off the intersphenoid phase. Even though this is a sphenoid IP, this is one where you can resect this disease to negative margins, and this patient can go home, frankly, the same day, because it doesn't involve any critical structures within the sphenoid sinus. So when you think of your surgical armamentarium for these tumors, certainly I think through-cutting instrumentation and rigid scopes are essential. This is an ophthalmic crescent knife. I would encourage you, if you do a lot of tumor surgery, this is an ophthalmic knife, to have this available. This is great for making cuts along the lateral nasal wall, septum, and within the paranasal sinus confines. Shavers, drills are important, and bipolar cautery as well. And when you look at the surgical strategy, and we're going to go systematically through maxillary, ethmoid, sphenoid, and frontal, but there's really a 2-fold kind of overarching strategy that you should use when you think about removing these tumors. First and foremost, you have to create an optical cavity. When you think about removing these tumors, it's actually quite intuitive. You have to be able to remove the free-floating tumor within the nose and really find the area of the tumor attachment or attachments if there are multifocal, and attack those areas aggressively, and then do margins if needed to ensure you've achieved frozen section histologic control. And if you do that, frankly, the risk of recurrence is quite low. So soft tissue shavers can be very helpful in rapidly debulking tumor. They can minimize blood loss. What I would caution you is this: for large tumors, what I will often do is use multiple traps to capture specimen. So I may create an anterior nasal cavity, posterior nasal cavity, anterior maxillary, posterior maxillary, anterior ethmoid, posterior ethmoid, so on and so forth. The reason for that is you're essentially creating a three-dimensional tumor map. And that's critical because somewhere in there, if there is, by happenstance, a malignancy hiding in there, if you have just removed one large specimen, how will you know where that malignancy was? So I think in a rough way, it can help you create a tumor map. And so consider that when you're using especially very large tumors. Now, this is a discussion that I've had with many colleagues across the world as well, and that's, is there a case to address the underlying bony attachment, that area of focal hyperostosis? And I think there's a time when some in our specialty posited that perhaps you could just do a submucosal resection, and that may be sufficient. But the reality is that when you start to remove these tumors, and this is a nice study that shows this tumor can interdigitate into that area of focal hyperostosis. So if you just do a submucosal resection, you can leave this frond of tumor that's in the actual bone. So drilling this down completely and getting down to normal bone is really critical to achieve complete tumor removal. This was a maxillary IP, and you can see here, as we start to drill, what I'll do is actually take that area of attachment, cauterize it, char it, and then use a drill, and actually that kind of serves as my roadmap on what I need to drill away to ensure all of that is cleared. And you can see all the mucosa circumferentially around that is completely gone as well. But the entire area of focal hyperostosis there is going to be drilled down to make that as clear as possible. It's a study out of Harvard that looked at this very issue. And what you'll see is that the overall recurrence rate was 12.6%. You can see here, if they only perform mucosal stripping, sorry, let me go back for just a second. What you'll see is the risk of recurrence was almost 50%. Drilling of the tumor base reduced the risk down to 4.9%, or complete resection, if technically feasible, can reduce it down to 0%. So no question, mucosal stripping alone is not sufficient. Now, on a case like this, a recurrent maxillary IP sent to me, you have to do a full medial maxillectomy to be able to get to this area. And that's critical because otherwise you can't see the very inferior extent of this tumor. And you can see there's been studies doing radiographic analysis of the maxillary sinus. And if the total volume of the maxillary sinus is 20 cubic centimeters, you'll see that almost 2/3 of it sits below the superior attachment of the inferior turbinate. So you have to get that down to be able to see that complete tumor. And anterior to the nasolacrimal duct is almost a centimeter. So these are your boundaries for the medial maxillectomy. Anteriorly is the lacrimal system. Posteriorly is the posterior maxillary wall, roof of the maxillary or the floor of the orbit, and the floor of the nose. Now, when I do a medial maxillectomy, unless there's an anterior wall attachment where I know I need to do a Denker's type, more extensive medial maxillectomy, I try to preserve the leading third of the middle turbinate. That has critical function for nasal conditioning, minimizing airway turbulence. So if you don't need to take that out, try to preserve it. Your patients will do better post-op. They'll have less crusting and other issues. But obviously, if there's a completely anterior attachment, you may not be able to. The other thing that I'll do is when I drill this medial maxillary wall down, I will actually create this trapdoor flap off the floor of the nose, which is based on the medial aspect of the nasal floor, elevate that, and then this can be draped right down onto that bone, and this will really minimize crusting and facilitate quicker healing. Now, when we address the maxillary sinus, there's a variety of different ways to do it. There's the traditional gingival buccal approach, which I've used certainly earlier in my career, and I'll show you one of those cases. Or you can do the medial maxillectomy. You can do an extended medial maxillectomy where you can remove the nasolacrimal duct very easily, and this can be filleted open with reliable patency. People have described the transeptal approach, even a septal dislocation approach, which is the only approach on this list I have not done, or a Denker's approach where you can remove the entire medial wall, which can also work quite nicely for anterior wall tumor attachment. So this is an older case. Just want to share something earlier from my career, a recurrent maxillary IP. And really the key point here, that a reason I wanted to show you this, was that the tumor attachment was along the infraorbital nerve. You can see the subtle thickening of the bone there, and then it actually tracked laterally. And I think even with the Denker procedure, getting all the way laterally and around the inferior lateral aspect of the nerve can be tricky. It's certainly achievable, but this was earlier in my career. So here you see just removing that tumor. Here's creating that medial maxillectomy, ophthalmic crescent knife, making the posterior cut first, so it doesn't, so it bleeds posteriorly, making the anterior cut right at the posterior to the nasolacrimal duct, and then this central segment can then be removed, and that reveals all of that free-floating tumor along the inferior aspect that's hiding. And here you see the tumor as I remove it. Here is the infraorbital nerve region, the floor of the orbit, and this entire area was broadly involved with the tumor. So at that juncture, I actually created a very small gingival buccal opening. You can insert the rigid endoscope directly through that. And then we're working with a 0-degree endoscope here, removing that free-floating component of the tumor. And you can see it goes lateral and behind the infraorbital nerve here. And then we're actually going to use a drill to drill down that last bit of the microscopic disease. Now, one of the things on a case like this that I learned was the fact that when you're drilling that infraorbital nerve canal, these patients get a lot of pain. He actually had preserved V2 numbness. I was able to preserve the nerve, but they do get a lot of just paresthesia and discomfort relating to tumor removal. This is the healed result at about 3 years in this patient, looking at the ethmoid cavity, anterior ethmoid, and then looking up into the frontal on the right side there. And then I'll show you the view with the 30-degree endoscope, looking directly into the maxillary sinus here. So pretty good healing here. This does not happen accidentally. This can take months for this to mucosalize and heal, and you really have to proactively manage that cavity to ensure good healing. This is my follow-up scheme. Certainly the risk of recurrence is highest in the first 2 to 3 years, so you want to follow those patients much more closely during that time period, maybe initially quarterly, then every 6 months. And certainly I tell patients that you ought to be followed for life. There's still a risk of recurrence more than 5 years out, and there's even a single-digit risk of recurrence more than a decade out. So I tell these patients once they're more than 5 years out, do an annual checkup. It's a quick visit to ensure that you're doing well. One decent-sized study with 35 maxillary IP cases showing that 70-degree endoscope and angle instrumentation can facilitate surgical access without need for Caldwell-Luck approaches. And certainly my own personal experience over the last decade, perhaps not the first 8 years of my career, would confirm that observation. Now, let's look at ethmoid inverted papilloma. And you can see here the thickening of bone in this recurrent IP, and that's this very broad area of attachment. In that case, oops, sorry, I'm going to go back. You'll actually see that I am going to take the entire lamina off the periorbita, because trying to thin that bone down for me is technically going to be harder. And so I developed a plane of cleavage between the periorbita, and essentially like you would if you were going to be doing an orbital decompression and removing that entire segment of bone, which actually had tumor interdigitated within that lamina. And I think it's safer that way because now the entire periorbita is preserved. I would also strongly advise that you can resect the lamina. On rare occasions, I've had to resect the skull base as well, but avoid periorbital or dural violation. If you do that, your next recurrence may be within the orbit or maybe within the brain. Those are great barriers for benign tumors spread, and they ought to be respected. Here's another case of an ethmoid inverted papilloma, and you can see here this area of focal hyperostosis. I showed you the CT earlier. Here's the MRI, quite a large extensive tumor. Even though that tumor was so big, the entire area of attachment was just this area. And I did have to do a DCR because there was some tumor involvement directly over the nasolacrimal duct bone. And then you can see the healed result here. There was no skull base attachment, really very limited lamina involvement in this case. Sphenoid, ethmoid roof, anterior ethmoid, and looking up into the frontal sinus, and you can see the lamina here, and you can see the nasolacrimal neosteum that's fully healed right there. So even though that's a very large tumor, again, creating an optical cavity, identifying the site of origin, that's an overnight stay in the hospital, and that patient can do very well. Now, when we start to talk about sphenoid inverted papilloma, certainly now the stakes are higher. There's also a level of surgical complexity that is significantly more. So you see this very large tumors. I approach these cases like I would skull-based surgery, and I may do these cases with a fellow or a faculty member or a neurosurgeon, depending on the complexity of the surgery. In these cases, to get wide exposure to the sphenoids, you need to do a posterior septectomy. You need to do an extended sphenoidotomy. It would be an incredibly rare, very limited tumor that I would manage through a unilateral approach. I would almost manage all of these through an extended sphenoid approach as I would for a clival or pituitary surgery. The key challenges here are risk to the carotid and the optic nerve, and looking to see if there's bony covering over those areas. And certainly for very large aggressive malignancies, and if they're, for large aggressive benign tumors, not malignancies, you could consider staging, and even in the best of hands, the risk of recurrence in these cases can approach 20%. So I showed you this MRI earlier. This is a patient with a very large sphenoid IP, epicentered in actually bilateral sphenoids, but this actually was large enough that it actually came out of the nostrils. That's how large this tumor became, neglected for a long period of time. I apologize that the video is jumping a little bit. So what we did is we were able to debulk this through an extended approach. And here you see now more of a three-handed approach, removing that tumor. And this was actually done with a neurosurgical colleague, and there was still a little bit of tumor left in the clivus and the right carotid. And once we lost, the visualization is suboptimal, we came back and did the rest of that case at a later date. So this is the healed result in this patient, as you can see here. You can see the extended approach. You can see all of the large portion of that septum has been removed. And you can see you're looking directly into the sphenoids, optic nerves here. You can see essentially mucosalized but dehiscent carotids on both sides. And on this patient, actually, I had them get a medical alert bracelet, and it said skull base surgery, no nasal instrumentation. Imagine if somebody tried to put an NG tube in this patient's nose if they were in the hospital, or somebody tried to do a nasotracheal intubation for some reason. They would potentially kill this patient. So with patients with very extensive skull base surgery, it's just 6 words. Skull base surgery, no nasal instrumentation. And it's essentially they get a medical alert bracelet made and they wear it. So a large pooled series looking at 48 cases of sphenoid inverted papilloma, recurrence rate almost 15%, median time to recurrence little more than a year. And in this study, what they found is higher risk of recurrence if there's dysplasia or carcinoma in situ, or if there's attachment directly over the optic nerve or the internal carotid artery. And intuitively, it makes sense, right? Because those are areas that are much more difficult to tackle when there is tumor attaching directly onto the carotid or the optic nerve. Let's shift to frontal. And frontal can also be very challenging. Obviously, here you're having to use angled scopes, dealing with the complexity of the frontal recess, having to use angled shavers and drills. But again, here we're often aggressively stripping tissue and bone, and then we have to try to prevent frontal stenosis. So there's a lot of competing goals that we develop in doing tumor surgery in the frontal region. And so that can certainly, all of that can add to the surgical complexity in these cases. Certainly in very select cases, there can be a role for open approaches. This is a trephine approach in the floor of the frontal sinus. This is a much older case, but it can be used, and it was used successfully in this specific patient. Osteoplastic flap, perhaps in very select cases, can be used as well. But perhaps the most critical approach will be doing the endoscopic modified Lothrop. This is a patient who actually had frontal headaches and had an MRI done 5 years prior to presentation, had a tumor in his frontal, was missed, and it continued to grow until he developed nasal obstruction. You can see all these areas of hyperdensity within the tumor. This is just spotty calcification. Here we're looking at the left side. I'm removing the nasal component of the tumor, and you can see some infection that's mixed in there as well. We actually did an extended drill out approach, and I was able to clear about 98% of the tumor. Unfortunately, in this case, the entire anterior wall was seeded with tumor, and I could not get that anterior wall through the drill out approach. Then you're stuck. So at that juncture, you have 2 options. You can leave that last 2% of the tumor, or you can do an osteoplastic flap, and you can essentially drill it down. And you can see here, I don't know if that's visible, but that entire anterior table was seeded with tumor, and then by drilling that away, you can see the a clear, healthy bone. You're able to replace this. This is about a 2-hour procedure just to do that osteoplastic flap, so it can be done safely in that patient. This is the healed result in that patient. You can see that frontal neoosteum, and we can see to the very top of the frontal sinus. You can see that kind of healing by secondary intention on that anterior table. There's no concern for recurrence. This is just some focal hyperostosis from cold water irrigations. It's a concept that's been described by David Kennedy. That is not tumor. We looked at this, a combined experience for colleagues with from South Korea, from Busan, and what we found is that in cases like this, multifocal IP, typically we needed to do a modified Lothrop or some sort of an open approach with a recurrence rate of about 22%. Again, as I manage sphenoid IP with extended sphenoid approach, I would tackle almost all frontal IP via an extended approach as well. So I think this is a last case that I have to show you. This is a patient that had had 12 or 13 previous surgeries. This is a case I managed, I believe, about a decade ago now. You can see massive frontal IP, really no bony anatomy here. You can see the erosion over the orbital roof. There's some sort of a supraorbital cell that's still present here. and you can see erosion of the crista galli here as well. This patient had a horribly infected nose, so I actually proactively staged this case. I actually did an endoscopic drill-out procedure to get the infection under control first. He was on culture-directed antibiotics for a period of time, and then subsequently we brought him back and did a combined endo-open approach. And this is actually looking right at the skull base. This is a technique you can use. This is fulguration of that scar along the skull base and the dura, and then using a suction technique to essentially gently debride that tissue down to negative margins and removing that last bit of microscopic disease. And you can see the healed result here, looking at the skull base, looking at the frontal sinus. You can see a fair bit of scarring here. That would not be unexpected because his entire frontal sinus, every surface, along with the orbital roofs, was involved with tumor. So we would not expect, would not be a surprise to see some scarring. But even with the secondary healing, you see very good overall healing and mucosalization without any post-op crusting. There's a nice study published out of Great Britain looking at this pooled data of squamous cell carcinoma arising within the setting of IP, 63 case series approaching 2,300 patients. You can see the risk of synchronous carcinoma that is arising at the same time, 7%. But amazingly, metachronous carcinoma, meaning you remove the tumor and a malignancy arises there subsequently later on, 3.6%. And you can see mean time to develop more than 4 years. So when I see squamous cell carcinoma arising within malignancy, within IP, unless it is a microscopic focus, if it is frankly invasive carcinoma, I treat this like malignancy. I don't care about the IP at that juncture. You don't want to undertreat the patient just because they happen to have IP in that setting. So negative margins, plus or minus chemoradiation, certainly radiation, possibly chemo, depending on the aggressiveness of the histology. Some studies looking at this showing reasonable recurrence or long-term disease control rates in these patients. Here you see this, so just switching gears for just a couple of more slides, looking at a systematic review and meta-analysis of more than 4,000 cases of sinonasal inverted papilloma and looking at recurrence rate based on the type of approach. And you can see here for purely, endoscopic approach, the recurrence rate is 12.8%, a purely external approach, 16%, and a combined approach, 12.6%. So using an endoscopic or a combined endo-open approach will give you the best outcome. And in fact, the external approaches have a slightly higher recurrence rate. Now, one could easily argue that are these external cases perhaps self-selected to be more advanced disease and therefore required an open approach? And I think that could be a reasonable argument, but I think there is data to say that the endoscopic approach may give you better visualization and may allow you to better identify the point of origin of the tumor. Now, circling back to a study that I reported very early on, when we classify these cases and you stage them according to Group A, IP limited to the nasal cavity, ethmoid, and the medial maxillary wall, when you group these cases, we actually do very well. The recurrence rate is only 3%. If it's any other wall of the maxillary sinus or frontal or sphenoid, the pooled analysis, almost 1,000 cases, the recurrence rate goes up to 20%, and anything that has extra sinus extension, then the case of the risk of recurrence goes up almost 1/3 of the cases. So I think that even though we can say that the recurrence rate may be 10% or less than 10%, the reality is it is really the point of attachment or where the tumor is epicentered is going to best predict how the patient's going to do and what the risk of recurrence might be. Two other critical points that I've learned that I want to share with you, and this is based on some recent research as well. This paper is out of France, 110 cases, reported about a 20% recurrence rate. And what they found is that for cases, when they did a Cox regression modeling, if they had previous surgery, so recurrent disease, had a 5-fold higher risk rate versus patients who did not have surgery. Another study looking at this, looking at cases that underwent surgery, and what they found is primary surgery, recurrence rate was 12.4%, recurrence rate was 22% in the setting of previous surgery. And interestingly, when there was multiple tumor attachment sites, that increased the risk of recurrence 3.5 folds. So how do you put all that data together? The way I understand it, when you look at this aggregate of data, no question that the recurrence rate is driven, one, by the location. Frontal, sphenoid, extrasinus are going to have the highest risk. Your best chance of getting negative margins and recurrence-free survival are your first time. And if you end up with a lot of cases like I do when they are recurrent disease, if they're multifocal because they've been previously manipulated or they happen to be attaching to multiple areas, unfortunately, those cases, even in the best of hands at academic centers, may still have the highest risk of recurrence. And these are important counseling points for your patients. So I think that my conclusions, obviously aggressive resection, I think the endoscopic approach, the data shows works well. Recurrent IP has the highest risk. Open approaches can have a carefully selected role. And regardless of the technique, long-term endoscopic surveillance is an absolute requisite. I want to thank you all for your attention. I want to thank the Tarabishi Stamberger Institute for the opportunity to speak with you virtually this morning.
Thank you very much. Very, very nice talk. You really have some difficult cases. So thank you guys, and thank you for joining us. Tomorrow we'll have two live sessions. Tomorrow one live session at 5 o'clock. Dr. Sethi from Singapore going to talk about complications of sinus surgery, and he really does that very, very well. He presents quite a few cases, and I think you're going to enjoy the talk. The day after, in the morning, and you will see it on the schedule, there will be a live transmission from University of Cape Town in South Africa about parotid tumors. So I'm pretty sure you will enjoy it as well. You know, if you have the app, you could push on the live button on the app, you know, next to groups, and you will be able to log in for Zoom. Of course, if you're using if you're going directly to the website without the app, you just have to push on live meeting. So thank you again, all, and have a nice evening.